I will be seeing answers in chat box or question answer box?
Chat box.
Okay, okay. So all students, you please answer these questions, and after you answer the questions, we'll discuss the things. So first question is, what is the best route and dose of IV adrenaline during neonatal resuscitation? Few people have written IV route. Most of the people have written umbilical venous route, and the dose written is 0.2 ml per kilo of 1:10,000 of adrenaline. 0.1 to 0.2 ml per kg of adrenaline. So according to newer NRP guidelines, the dose to remember is 0.2 ml per kilo, but the dose remains same is 0.1 to 0.3 ml per kilo of 1:10,000. How we have to dilute that? We have to take 1 cc of adrenaline and 9 ml of distilled water or saline you have to take and make it from 1:1000 to 1:10,000. And then you should consider by giving through central line. So umbilical venous line is best when you are doing extensive resuscitation of the child. But while doing that, if you are not, if it is getting delayed for putting umbilical line, or if you get, you need some more time. So during that time, you can use endotracheal also instillation of IV adrenaline. But dose is 1 ml per kilo of 1:10,000. For 3 kilo child, you have to instill 3 ml of adrenaline through endotracheal route and continue CPR of this child. And you should not count this dose till you are able to put the central line, and then you should consider for repeating the doses every 3 to 5 minutes. Clear? Now, second question is when to stop resuscitation. So answers coming are 20 minutes, then 20 minutes of extensive resuscitation till there is no response. So the answer is in spite of coordinated high-quality chest compressions and effective positive pressure ventilation through the endotracheal tube with 100% of oxygen and adequate medications, we should continue it for at least 20 minutes. Clear? Now, the next question is, what do you mean by 4 E's in B4E and beyond module of UNICEF? Please answer in the chat box. So no answer is coming. One answer has come. Early initiation, every baby, exclusive breastfeeding. You are close to the answer. So this is a actually B4E and beyond is a new term or new module which has been coined by UNICEF, and in IAP they have produced a module which they are taking workshop also for training the people who are pediatricians, gynecologists, as well as the staff nurses, for training them for breastfeeding for every baby, every time, exclusive and early. So these are the four E's for B4E and beyond workshop. And what is beyond? Beyond is SVN, that is small vulnerable newborns. They have included in that. And these small vulnerable newborns are nothing but term SGAs, preterm SGAs, and preterm babies. So these SVN babies contribute for most of the mortality. And feeding of these babies has been discussed in this UNICEF module. So this is early, exclusive, every time and every baby breastfeeding. I will go ahead. Question number 4 is this is for stats. This is on stats. In block randomization, how many blocks can be made if two treatments, that is treatment A and treatment B is there, and I want to make each block of 4. So how many blocks can be made? Please answer in the chat box. In block randomization, how many blocks are made if there are two treatment options? One is treatment A and treatment B, and I want to make each block of 4. No answer is coming. I will wait for 10 seconds and I will try to answer. So the answer is 6 blocks are made. So see that in a randomized control trial, you are going to make two groups, which is the group which is going to get a intervention and another group which is not going to get a intervention. So during randomization, there is always a doubt that you will have an unequal number of intervention and non-intervention group. To avoid this, we do block randomization. And for block randomization, we make even numbered blocks for two interventions. So two blocks, 4 blocks, 6 blocks, like that it has been made, so that by the end of the study, you will get equal number of allocation into the treatment group and non-treatment group. So here, if the two interventions are there, A and B, so these such kind of 6 blocks are made, and of these 6 blocks, we gradually follow the selection of treatment or non-treatment getting. So such 6 blocks are made. So you should know that what is block randomization, why randomization is done, and the importance of block randomization. Clear? Now, another question is, which test is used to differentiate maternal from neonatal blood in case of GI bleed? Now answers are coming. Everybody is answering APT test. So APT test is basically used to differentiate between maternal and neonatal blood. So the APT test is done by using sodium hydroxide, and this sodium hydroxide is used because fetal hemoglobin is alkali denaturation resistant. That's why whenever you add sodium hydroxide into a aspirate, GI aspirate, so if maternal blood is there, that will turn into black brown. And if it is fetal blood is there or neonatal blood is there, it is going to resist alkali denaturation, so it will be red. So this APT test is useful for differentiating between maternal and neonatal blood. So the question is, So please see this equipment and what is the name of this equipment, what is it is used for, and what is the standard criteria to use this. Please answer in chat box. One has written transcutaneous bilirubinometer. No answers. So this is the equipment. Basically, it is flux meter. So this is eye of the flux meter, and this flux meter is used to measure the flux of phototherapy machine. Basically, the flux meter should be used routinely for measurement of flux of your phototherapy machine. So the flux is mentioned in microwatt per nanometer per centimeter square, and the flux should be measured on a routine basis. The eye of the this flux meter should be facing towards phototherapy, and it should be at a distance where usually you are keeping the baby between 12 to 15 centimeter. So if double surface, if you are using, the eye should be turned to the down if down surface phototherapy is there, and addition of this flux is made, and that much of flux the baby is getting. Like that it is used. So this is flux meter. Now we'll go into focus. So what is use of resistive index in anterior cerebral artery, and what is the normal value for that? So what is RI in anterior cerebral artery when you are doing neurosonography of a neonate, and what is the normal value of that? So one has written in hydrocephalus it is used. One has written it is used in IVH. The normal value is 0.7 to 0.9. 0.7 has been written. So you should all be trained in neonatal sonography and echocardiography. So somebody has written used in IUGR, IVH, and HIE. So we'll go ahead with the answer. So usually it is used in birth asphyxia. So birth asphyxia, neurosonography parameters, by just naked eyes, you can see that there is loss of normal architecture, that is sulci gyri pattern is lost, and ventricles will be thickened, and there is diffuse increase in the echogenicity all over the brain. So here you are finding that the loss of sulci gyri pattern is there, and the ventricles are thickened. Thickened means small ventricles have become. Now, the objectively, you can monitor that by calculating the resistive index. So what is resistive index? Resistive index is nothing but peak systolic velocity, which is this peak systolic velocity minus lowest diastolic velocity divided by peak systolic velocity. That is systolic minus diastolic divided by S. So how we calculate that? So you have to keep in mind, do the sagittal view on neurosonography, keep the cursor on this side, and try to locate the anterocerebral artery. You have to put pulse wave Doppler here. So here you are finding the pulse wave here, and by seeing the pulse wave Doppler, you can find out, when you update this, you will get the waveforms which I am going to show in the next slide. But while putting such pulse Doppler, your scale should be between -30 and +30. Then only you will get a low velocity Doppler in that. If you are keeping, when you are doing echocardiography if you are seeing the major vessels where there is a large flow or high flow is there, where you keep the scale between 70 plus 70 and minus 70. But here you have to reduce your scale, and then you will be able to see the intracerebral artery. And here you are going to see, calculate the resistive index. So what you will find after updating that, you will find this as this is a peak systolic velocity, and this is diastolic velocity. So the resistive index in this child is 0.53. So the normal value of resistive index is 0.74 plus or minus 0.08. So resistive index should not be less than, means it should be between 0.5 to zero point 0.9. So basically, you should daily monitor the resistive index of the child for prognostication of a newborn. So in case of severe birth asphyxia, this is an upcoming parameter where you can, which is useful for prognosticating the child as well as counseling the parents that how whether the baby is improving or deteriorating. Now, another parameter I'm putting in front of you, what is delta pulsatility index or delta PI, and where it is useful, and what is abnormal delta PI. Please put your answers in chat box. What is delta PI? So these two questions I had put from neonatal focus. You people should be trained in neurosonography and echocardiography. This is very simple parameter. Anybody has answered what is delta PI? So I will try to explain. So this is simple pulse oximetry test where the pulse oximeters which are using the technology of SET, that is sample extraction technology. So when you are putting the pulse oximeter probe, you will find pulsatility index, and this pulsatility index at day 1 should be more than 0.85. So the highest and lowest pulsatility index means preductal and postductal difference you have to find out. So preductal and postductal difference, which is delta PI. So if it is more than 0.85, it is considered hemodynamically significant PDA. And after day 3, if it goes beyond 0.95, then it is considered as significant PDA, where you can consider for treating this PDA if other parameters are supporting for that. Now, we'll move ahead with another question. Which nerve roots are affected in Duchenne's palsy? And another part of the question is absent palmar grasp in Duchenne's palsy, whether it is true or false. The question is which nerve roots are affected in Duchenne's palsy, and absent palmar grasp is there in Erb's palsy, whether it is true or false. One person has written C5 and C6. What about palmar grasp? Whether it is present in or absent in Erb's palsy? It is a differentiating point between Erb's and Plumke's palsy. In which palsy it is present and in which palsy it is absent. One person has written it is false, means palmar grasp is present in Erb's palsy. So the answer is correct. So in Erb's palsy, the nerve roots affected at C5 and C6, and typically the feature will be like Porter's tip deformity the baby is going to have. And the arm is adducted, pronated, and like Porter's tip, the patient's palms will be there. And it is false that palmar grasp is not absent in that. Palmar grasp is present. It is absent in Plumke's palsy. It is one of the differentiating point between Erb's and Plumke's palsy. Now, the last question which I am going to take is, what are parameters of septic screen and what are the cutoff values for that? Very simple question. CRP, TLC. Please mention cutoff values also. $4,000, less than 4,000. ANC, CRP, micro ESR, and I/T ratio. Micro ESR 15. Any age specific things are there? I will tell you. So TLC count less than 5,000 per cubic millimeter. Absolute neutrophil count, you can follow Monroe's or Mozzino's chart. If it is less than 1,500 or age specific nomograms also are available, you can find that. So immature to total leukocytes, you can find that. Immature to total neutrophils, if it is more than 0.2 in preterm and more than 0.27 in term. CRP, few lab values mention more than 6 milligram per deciliter, but we follow more than 10 milligram per deciliter. And micro ESR for first 7 days. So age in days plus 3 means if the baby's age is 5, so 8 we have to consider as significant. And after day 7, more than 10 is considered significant as micro ESR. How micro ESR is done? Can anybody tell in chat box? How micro ESR is done? So we have to take the capillary tubes, and yes, capillary method is used for that. We have to hang on the wall by plasticine sealing on the lower end and wait it for 1 hour. By the end of 1 hour, how much is the fall in PCV? The upper portion is measured, and that will be the micro ESR of the child. Thank you. Thank you very much.
Thanks, Dr. Sandeep.
Thank you, ma'am.
Such an interesting OSCE. Some questions were simple, but some I think the students, they were all bouncers. So, but it's good because it challenges them. So they will be now motivated to read more than beyond what they already know.
Thank
So
you, ma'am.
thank you so much. And so that we come to the end of the FEEP session. I thank all the participants, and we'll see you next week.
Thank you, ma'am. Bye.
Thanks, Dr. Good night. Good night, Sarita.
Good night, ma'am.